Okay, welcome to Spine Conference. Today's November 6th, so it's the Thanksgiving month. And I want to thank everyone for coming. And today's topic is going to be posterior cervical laminectomy fusion up to C2 for adjacent segment degeneration. So I like to do illustrative cases because it's a good way to remember things. This is it's not our actual patient, but she looks very similar to that 80-year-old woman. Good morning. Good morning, Mr. David. Come in. 80-year-old woman with neck pain, and she's had this pain for many years, and she's just dealt with it. But I guess it's gotten to the point where she doesn't want to deal with it anymore. And why people tolerate pain for years, I don't know. I mean, I would not tolerate pain for years, but I would tolerate pain for months, but she's had it for years. Her hand trembles. She found me through the internet, which is kind of remarkable, because she's 80 and she's that tells you something about her vitality, is that she's sort of with it, and mentally she's very strong mentally. Her left hand spasms and claws up. Her left hand trembles. Her whole body hurts sometimes. She has a non-specific left arm pain. Minimal symptoms in her hand, so her hand dysfunction is normal. Her past medical history: she had a previous C4, C7 anterior cervical fusion in 2008, so 7 years ago, with good results. She had a CABG, coronary bypass graft, in 2004, and MI, so she has a cardiac history. She's on blood pressure medications, Wellbutrin. She's right-hand dominant, lives with her son. She's a widow, 4 children, non-smoker, no alcohol. She's a small woman, 5 feet 6 inches, 170 pounds. Well, not super small, but not large either. But I guess 5'6" for a woman is kind of average, I think. I don't know, what's the average? It's like, is that about 5'4", 5'6"? Okay, I just think I guess she's not small. She's like an average woman. And otherwise, normal physical exam, except for a very stiff neck. She can only rotate maybe 20 degrees, and very minimal flexion extension. So is there? So basically, if I had to sum up her history and physical: neck pain and stiffness, and she's had previous cervical surgery. So, so any questions so far? No. Okay, what would you all do for her as rehab? Let's say her primary care physician, which is very common, sends them to therapy.
Well, we would look at muscle tension, certainly, alignment, and depending on if she's osteoporotic, work on some of the alignment issues manually. Give her some postural exercises, some stretching.
Like what for neck pain? She's got neck pain and stiffness.
As far as postural exercises?
Mm-hmm. Yeah.
Just some gentle stretching of maybe the scalenes, the upper traps, some doorway stretches into her pecs.
So you give her like a program and you tell her to do it? How's it work?
It depends on the patient.
Let's say if it's Aaron.
If it's Aaron
Non-compliant.
would be non-compliant. Well,
she's compliant. She's compliant.
Compliant.
Yeah.
Yeah, we do give him 100 things to do with him, just a few basic
100?
things. No, would not give
Oh.
because patients aren't going to do that.
Right.
3
so
or 4 things to
3
do
or 4
throughout the day. And then,
yeah. And how many times a day?
Progress with that. Usually twice, because if you give them 3, they're not going to do it. They're lucky you get 1.
So 3 exercises a day. Good morning, Alan.
Morning.
3 exercises a day, and tell her to do it twice a day.
And it's usually about what they can handle initially. We have a good aquatics program too, so we sometimes will, if there's a whole postural strength deficit endurance issue, we'll try to give them in the pool.
Where's the pool?
At the Y.
At the Y? Is it heated?
It is. It's not heated.
What's the temperature?
It's heated. It's about 86 degrees.
Oh, that's pretty warm.
Yeah.
Okay. All right, so just Alan to bring up to speed, 80 years old, neck pain for years, and stiffness, no deficits, and she's had previous cervical surgery. So I want to just review this just because it's, in this case it's not relevant, but in most cases it's relevant, is how do you assess cervical myelopathy? And this is the Modified Japanese Orthopedic Association score, which is a very good way to score myelopathy. And it goes over motor dysfunction, So motor dysfunction in the sense, inability to move her hands, inability to eat with a spoon. The best is no dysfunction, and the next to best is able to button shirt with slight difficulty. So I guess buttoning a shirt is something that we do, buttons are something that we do every single day, and it requires a lot of dexterity. Motor dysfunction, so no dysfunction, and the next one up is mild lack of stability with smooth, reciprocated, unaided. And then able to walk up and down steps using the handrail or not using the handrail. So me, I use the handrail, so that would put me at, I mean, I do. So where would I be? Able to walk up and down with handrail. I'm a 4. And sensory dysfunction of the hands and sphincter dysfunction. So just, guys, just give me 1 second.
This is a model of the cervical spine. I'm in my house, and during surgery you don't have the luxury of moving the model around, but in your house you do. So I think it's important to understand the anatomical features. One is the bifid nature of C2, and C1, as you know, you just have an arch. So lateral mass screws are pretty straightforward. You can easily find the medial border, of the lateral mass, lateral border. Then I usually go just slightly medial to the midpoint, and then I place a Penfield 4 into the facet. This is really simple, very safe, and it gives you the exact angle that you need. And you just follow that same exact angle superiorly and laterally so that you miss the vertebral artery. See the vertebral artery? So you want to stay lateral to the vertebral artery for that. Now for C2. There's 2 different ways you can go: more lateral approach and more superior medial approach. In my mind, the more inferior lateral approach will give you a longer thread screw, and it's a slight medial angulation. So it should follow the facet, as you can see there, and it has to be medial to avoid the vertebral artery. Now, obviously, every single C2 is different in people, so you have to very carefully both study the model and also the CAT scan for the individual patient. Now, in my mind, the short pars screw is very safe. It just goes up to the level of the artery, so you got to measure that pre-op. So you get a much shorter screw. But for a degenerative case and not a fracture case, which is this case, a 14 millimeter screw I think will give plenty of fixation. That's a short par screw. It just basically goes straight in, and you just measure it pre-op so that you don't get as deep as the artery. And just for completeness sake, the C1 screw is just inferior to the arch, pulled down the nerve root, just above the facet. The facet you debride so that you get a fusion, usually C1, C2. It's a slightly medial angulation. Here's the starting hole. Slightly medial angulation. See, obviously you don't want to end it into the neck. So I thought this was a helpful depiction of the C2 screws. This shows you the angle has to be parallel to the facet joint.
Lateral mass screws are used at C3, C4, C5, C6, and sometimes C7. And lateral mass screws are in line with the facet joint. You can see that in the middle, and are pointed outwards because you don't want to hit the vertebral artery, which is right there. So they have to be pointed lateral. If you put them straight in, you could hit the vertebral artery. The vertebral artery, of course, you could cause a brain injury.
When you're in the OR, you obviously can't see the whole of this. So how do you know you've chosen the right angle?
From that is in your mind's eye. So you know that from preoperative planning and understanding the anatomy. In the OR, you can hardly see anything. So you just see like a little circle, you know, of visualization, and it's bleeding at the same time.
A dumb question. What are you doing with those screws? What are you doing?
I'm just putting a screw in a bone to hold it still to get it to fuse. So it's a fusion. You weld the bones together, but if you put screws across bones, it holds them still, and it significantly increases the fusion rate. So let's say you just don't use screws at all, which the companies, it's anathema to the companies. It's a disaster because they don't make any income. So that's why nobody ever fuses without screws, because the companies really push the screws because they make a lot of income from it. But before screws, people used to fuse, surgeons used to fuse the spine all the time. You can still fuse it by drilling the bones and putting in bone graft, but the fusion rate is slightly smaller. I mean, not terrifically smaller, but significant, like 30–40% less probability that you get the bones to fuse. So by holding bones still with implants increases the fusion rate. But it's not zero. I mean, you can still have a very successful surgery without implants, but it's just better with the implants. So we, as orthopedic surgeons, we always see how can we put the screw in the bone to hold it still. So these are just techniques of instrumenting the spine. And there's many different articles. On the right is Howard and Paul Anderson's in the middle technique, and Majorel on the left, and he was the first one to describe how to put in a lateral mass screw. They're all very, very similar. So the outside angulation is somewhere between 10 and 30, and upwards, between 15 and 30. But during the surgery, I mean, there's no way we can tell the difference between 5 and 15 degrees. So these are just academic points. I basically just follow the facet. I follow the facet line. I can easily do that in the surgery. If you have to instrument C1, this is you can see the points of where you insert the screws at C1 and C2. And C2 is in lateral mass, and then you go medial to avoid the vertebral artery if you put in a C2 pedicle screw. The other thing you can do in C2 is you can just put it straight in, as it's called a short pars screw, which is not as strong, but you avoid the vertebral artery. So it's kind of like the recurring theme, avoiding the vertebral artery. So here on the top is a good screw at C2, and you see how they avoid the vertebral artery. But man, is it close to the vertebral artery, right? I mean, and the way I look at things is, why would you want to take a risk with someone's brain if you don't have to? So what I would rather just put in a short screw. There's no chance to hit the vertebral artery. And on the bottom, you can see the screw is in the vertebral foramen, which is obviously bad. So those are the issues at hand. So back to our patient now, problem list. So she has neck pain and stiffness, severe stenosis, C3, C4, C4, C5, advanced age, she has some comorbidities, cardiac history. C17-1 has spondylolisthesis. Do we use bone graft to fuse it? Laminectomy? Do we go anterior, posterior, both? So is any questions or comments so far? What do we do for this patient?
Isn't her stenosis C3, C4 greater than C2, C3?
Yeah.
Okay.
Yeah, I made a mistake there. I did that this morning. So any questions so far? So does anyone want to say how they would approach it in the front? Now in the front, anterior surgery is a lot easier than posterior surgeries because you don't cut through muscles, you kind of cut around muscles. So the anterior approaches do a lot better than the posteriors. So as far as the patient recovery, it's a lot easier for the patients to recover from anterior surgeries than posteriors. The problems with anterior surgeries is difficulty swallowing, basically. So people have dysphagia, difficulty swallowing after the anteriors. And also you can injure vital structures in the neck, which are extremely rare but possible, like the carotid artery, trachea, esophagus. So the problem in C2, C3 is it's very, very difficult to do an anterior C2, C3 surgery because the mandible, the jaw gets in the way. So I've done it before, but it's very hard. You can do it in people without teeth, because if someone has no teeth, you can close their mouth another inch. You never think about these things, but surgeons do, because we're always doing these things. So we often do surgery on older people who don't have teeth, and you can really close the jaw and push the mandible and get up to C2, C3 if someone has no teeth. But it's still difficult. So C2, C3 may not be possible in this patient from an anterior approach. So then the question is the posterior approach. So posterior approach, you can decompress the spinal cord posteriorly, remove part of C2, all of C3, C4, and then fuse it, because she would be weak in that area. It'd be optimal to fuse it. Instrument is better because it increases your fusion rate. And then the question is, what do you do about C17-1? I mean, do you include that or not? Does anybody have comments or questions so far? So to include it, that means you have to go all the way down to T2 now. Now we're talking a much bigger surgery for this person. And I'm not sure if C71 is causing her any problems at all. Maybe it is. Maybe it's a source of pain, but it's not compressing the spinal cord anyway.
Clinically, how would that manifest, Susan?
Pain, and if the C8 root starts to get compressed, they will get fourth finger numbness, which she didn't have any.
Would you be able to tell that was C7 rather than C2 in terms of the origin?
No, there's
How
no
about
way to know.
How about function?
Well, if they start losing their hand function, then it's clear it's a C8
Yeah.
nerve root. So I asked the patient, because the way I practice medicine is I ask patients. Sometimes they have no idea, but sometimes they really have opinions. So I feel it's only fair to ask them what they think. And she said, I don't want a big surgery. She said, I want the very least amount of surgery possible because I'm old, I'm frail, I don't want to have to deal with a big recovery. So then,
How old is she?
80. So she said, I want the least amount that you think will work. And I told her we can just, like, we won't do C71, but if it becomes a problem in the future, we can always go back and fix that, and it's a smaller surgery if we do it all at once. So that's what she picked. And then the question is, what do you use for bone graft? You can use the lamina itself, you can use synthetics, you can use iliac crest. So when you do these surgeries, a fusion surgery, it's a race. It's a race between two opposing forces. The white jersey force is a non-union and implant failure. So, and the red jersey is a bone fusion. So if the bone fusion wins the race, the implant doesn't fail. But if the bone fusion is very, very slow, the implant fails and you get a non-union. And if the implant fails, usually it doesn't heal. Like it just keeps moving and you get a non-union. So that's the thing with fusions and implants, and why implants fail. It's because the fusion never took. Does that explain? So I basically I elected to use iliac crest just because it's a conservative and it's the best way to get things fused, and it's a posterior approach. So she's laying on her belly. So I took it from the posterior superior iliac spine, which is on the top there, and then that just shows you where the gluteal musculature is right over that. So that's why, Aaron, if we don't do a good job attaching that back post-op, people have pain there because the gluteal musculature origin's gone. So that's why we take great care to repair that. And if you do a good job, people don't have symptoms really. And then I usually backfill it with allograft as well. So this is the post-op. So she had a partial C2, complete C3, C4 laminectomy, fully decompressed those levels, and I instrumented and infused C2, C3, C4, C5. And those are lateral mass screws, and you can see on the top right the vertebral artery right here. So, I mean, I could have put in a longer screw. I mean, I measured preoperatively 12, 13, 14 millimeters, but I didn't want to take a chance. And I felt the fixation was very strong intraoperatively. And this shows I could have probably gotten a couple more millimeters from this short par screw.
Now explain again what you've done, please.
I'll show you. I took the pressure off the spinal cord and from the back side, C2, C3, and C4. You see there's no bones here anymore. So now the spinal cord can drift backwards and has plenty of room because of the posterior laminectomy. You still have the discs pushing in from the front, but now that there's nothing on the back, there's more room for the spinal cord. The spinal cord doesn't need that much room. It only needs a couple millimeters. So the posterior approach is fine. Because I took bone away, that weakened the spine, so I want to weld it together so that it doesn't create a deformity, like get instability, etc. So I fused C2, C3, C4, C5 from the backside approach. Does that explain it? And just to show the C2 screw, I could have probably put a longer screw in because I'm not that close to the vertebral artery, but that's just basically what I did. I like to have a margin of error. And this also shows the lateral mass screw here. It gives fixation to this part of the bone, the lateral mass, and here's the vertebral artery. And this screw is actually perfect. And if you break something, you break this piece off. That lateral part, Aaron, breaks off. And then you don't have a screw there. So you can see this was like in this woman, there wasn't much margin for error. It had to be sort of perfect. Everything had to be perfect. And the case didn't go perfect, actually.
If you did get too close to the vertebral artery, what would happen? It would clot, it would bleed, or what would happen?
Yeah, so you knock off the vertebral artery. Let's say you do that. Most people don't have any problems.
But older people would.
But older people would because they don't have much reserve. So they have atherosclerosis. So there's a chance that they could suffer a stroke, basically. But people come in through shock trauma all the time with their vertebral arteries out from traumatic injuries, and they're fine. But not always. So it leads to a brain injury. But usually not. Usually if you just knock off one, they're okay. But I mean, I don't want to take a chance with someone. So I usually like to give myself a margin of error of at least a couple millimeters. So any other questions about this case? So you may want to ask, how'd the patient do? She's okay. She's in rehab. She's still somewhat weak. She feels that her ataxia. Did you see her?
I didn't.
I saw her 2 weeks post-op. Her ataxia is better. She feels like she walks better, but she says she's just weak and hurts all over. But I mean, I think it's a reasonable so far outcome, and giving her age, that you can't expect her hopping and skipping from this big surgery. But she's better. I mean, hopefully within a month she'll be fine. That's what I hope. In a month she'll be home fine. She'll be walking without assistance. No surgery, she would have never gotten better. It would just do this constant decline. So any other questions? Any questions at all, or about anything? C2, posterior laminectomy fusion instrumentation.
That's very helpful, thank you. I do have one question though.
Yeah.
At what point would you or do you do a bone stimulator for a patient? Like, if they're not beginning?
Like an external bone stimulator or internal?
External.
So an external. So there's two types. The external, which is basically, it looks like a big medallion, and then the internal is these wires that you put in over the fusion mass that's connected to like a little. It looks like a pacemaker. It's underneath the skin. I usually don't do them every single case because they cost money and they're a hassle for patients. So I do on people who don't heal. We're not healing.
Right, but
So people who
what-
have pain at 6 months.
What
6 months.
time frame? 6. Thank
So
you.
say patients at either 3 or 6 months, they say their neck hurts a lot, and a CAT scan shows it hasn't healed, then I order a stimulator. And I mean, in my experience, just off the top of my head, it's like 50-50. Some people do go on the fuse with these external stimulators, like ultrasound external stimulator makes the bones heal. Some don't. I never use the internal ones. The fusion rate in cervical spine is very high.
Right. I'm just curious, not you specific, but some other outcomes I've seen.
I use
Where's the
stim-
criteria?
I use external simulators. I've probably used like 5 in the last 2 years. People who didn't heal. So any other questions about posterior?
Could I see the slide of the finished,
Yeah.
the finished surgery?
This one?
Please again.
This one?
Yeah.
Yeah. So on the left is an AP view. On the right side is CAT scan lateral view, which just shows this C2, C3, C4, C5 instrumentation.
This is sort of a rod connecting
Yes, screws and rods.
the lateral mass.
Yeah, but the key is that the key to the fusion is you drill the bones and you stick bone in there to get them to heal up. That's the most important part of the whole surgery.
Oh.
The screws just hold things still until the fusion takes. So you can't see the fusion.
You make holes and put bone.
Yeah. I drill and make bleeding bone, and I weld. That's how you weld it together. That's the most critical part of the operation. You just can't see it on the X-ray, so you don't think about it. So any other questions or issues?
Wait, where where are you going to put the screw? No.
Right next to it.
Right next to it.
Can I point out the date is incorrect on your sheet?
Oh, I'm sorry.
Should be 11/6.
Can you guys cross it out? Yeah. All right. Thanks for coming.
If that-
Thank you.